Welcome to Finance 101 training. I'm Tabitha Stone, Program Coordinator at the National Rural Health Resource Center. Finance 101 is meant to provide that basic education on financial statements, budget, and the preparation process, hospital and physician payment systems, value-based payment models, and ways to think about improving your overall financial performance. This training will help create that understanding to link your clinical operations to your financial performance. The National Rural Health Resource Center is a nonprofit organization dedicated to sustaining and improving healthcare in rural communities. We're the nation's leading technical assistance provider and knowledge center in rural health. The center has served rural health organizations and partnered with FORT for nearly 25 years and collaborated with the Delta Regional Authority for nearly 15 years. We are committed to diversity, equity, inclusion, and anti-racism, and building a culture where difference is valued. With the support of Delta Regional Authority and the Health Resources Services Administration's Federal Office of Rural Health Policy, the center administers the Delta Region Community Health Systems Development Program and manages the provisions of services to selected healthcare organizations and communities over a multi-year program period. It helps to make those in-depth health system enhancements to position organizations and communities for population health. It's my pleasure to welcome our speaker, Eric Schell. Eric, I'll turn it over to you to introduce yourself and start the presentation.
Tabitha, thanks for the introduction. My name is Eric Schell, and I'm a principal and chairman of Stroudwater Associates. For the past 27 years, I've traveled around rural America, helping many critical access hospitals, small rural hospitals. Primarily, my background's a CPA MBA, so it's primarily from the finance background. This is a presentation that I developed about a year ago. And the more I've presented it, the more interested I've become in the divide between clinical and financial. I was at I gave this out in Honolulu to the critical access hospitals of Hawaii back 3 weeks ago. And we didn't get 6 slides into this thing in a 45-minute session because there was so much exchange, both from the finance people who just by default assumed the clinical people knew exactly what was kind of included in this presentation. And the clinical people had no idea about this content. And so often the two would, kind of ships passing in the night. They would not see eye to eye. This presentation is really meant as an education of the clinical people around kind of Finance 101, from an accountant who wanted to be an accountant into 10th grade to the department managers or to the CFOs and the finance experts within our hospital organizations, to have them understand what they do and don't know about their clinical staff. So with that, let me jump into this and kind of talk about what we're going to do. As Tabitha mentioned, we're going to start off with basic hospital or financial statement, kind of statements, metrics, conventions. Then we'll talk a little bit about how do hospitals and physicians get paid, primarily focusing on Medicare, as Medicare is the basis for other payers, commercial and Medicare Advantage and Medicaid. We'll talk a little bit about value-based care. And then the last area I think is the most interesting is, if a hospital is struggling, what are the 3 things that I look for in fundamental improvement in financial and operational performance? There's 3 things. And as I travel around, the organizations that do these 3 things better than others tend to be successful. So that's how we're going to lay this out. Our goal is to kind of wrap up in about an hour. Hopefully we're successful there. And then leave some times. Tabitha is likely to ask some questions if we can get enough time to do that. So that's what we're going to talk about today. Looking forward to it. Have your extra cup of cappuccino and espresso because this is an accountant who wanted to be an accountant in 10th grade talking. So the first topical item: financial statements and basic financial conventions. This is the one I've just really surprised at. the difference between accrual basis and cash basis accounting. I just assumed everyone knew exactly what this was, and it's not. But it's really important because our hospital financial statements are generally on a cash basis. But most people outside of the finance people live in a world of cash basis. Cash basis accounting principles mean that revenue is recognized when you receive the cash. Expenses are recognized when you pay the cash. And what's interesting there is that you may deliver a service today, but not get paid for 2 months. On cash basis accounting, even though you deliver the service today, you don't recognize that as revenue until 2 months when the cash comes in. On the other hand, expenses. You may incur an expense today. I'm working today, but I'm not going to get paid for today's work until 2 weeks from now on the 1st of March. So in cash basis accounting, I would recognize my work today as an expense on March 1st. Accrual basis accounting, on the other hand, says we are going to recognize revenue and expense when the revenue was generated and the expense was incurred. Thus, I'm delivering a service today in the hospital. I provide a CT scan. On accrual basis accounting, that revenue is recognized today because that's when the service was provided. Even though the cash may come in 2 months from now, the cash isn't relevant to me in terms of revenue recognition. On the expense side, I work today to deliver that CT scan, although you would never want me delivering a CT scan. Remember the accountant from 10th grade. And so I work today to deliver the CT scan. My expense is recognized today, even though I'm not going to get paid for March 1st. Major difference. All of our financial statements within our hospitals and let's just say our hospitals is recognized on accrual basis, meaning revenue recognized when the service was provided and expense was recognized when the service was, or when the expense was incurred. So big important, basic building blocks to financial statement understanding. The next, and I just want to show that many of us are critical access hospitals out there, and the critical access hospitals, it's interesting because generally the way you get paid is you get paid based on last year's Medicare payment rates, whether that be your per diems that you received last year based on last year's cost report, or your ratio of cost to charge, your weighted average ratio of cost to charge from last year's cost report. The problem with that is that if last year my rate per day based on my Medicare costs versus patient days was $930 a day, if for some reason my volume were to decrease, my costs aren't going to go down because for the most part, we're going to have a standard staffing model. Our variable expenses may go down a tiny, but for the most part with inflation, our expenses are going to stay the same, but our volume dropped. Our cost per day, our real cost per day that we'll get paid when we submit the cost report is going to be closer to $1,100, the $1,094. But all during the year, when we receive that cash, we're recognizing revenue at last year's rate. So by the end of the year, Medicare will owe us $257,000. The inverse is true. If volume goes up, our rate per day is going to go down, and our Medicare we're going to owe back. The problem is not that we're going to either owe back or we're going to get money from Medicare in the cost report. The problem is we make decisions with our financial statements, assuming that they're accurate. And if we're booking last year's rates to this year's financial statements, and we've either had a big increase in costs or a fluctuation in volume, we are not looking at very accurate financial statements. So it's something to be aware of, especially for, within our critical access hospitals. The next is we are going to look at the income statement, and we're going to break down the income statement into statement of operations, income statement. There's lots of different terms for it. But overall, there's three basic financial statements. There's the balance sheet, the income statement, and the statement of cash flows. We're going to not get into the statement of cash flows because that's for the accountants to play around with. The two most relevant statements for everyone to understand is a balance sheet and an income statement. We'll start with the income statement, which and what you're seeing here is you're seeing just the income or the revenue part of the income statement. So there's a difference between net revenue and gross revenue. Gross revenue are our charges. And in this hospital's case, if you can see, and why don't we just go to the last three columns where we're going to look at their actual total gross charges. And for this hospital, for the year ending 11/30/2022, their gross charges were $41 million. Their budget was $42.3 million. So they were off of budget about $1.1 million. But gross revenue, our charges, this is all of the charges entered into our system, broken out between inpatient, outpatient, and clinic over the course of the year. But that's not going to be the cash that we receive, because we have contracts in place with third-party payers, Blue Cross Blue Shield, United Healthcare, that they're not going to pay us our charge. They're going to pay us a discount off of charge. Medicare, if we're a critical access hospital, we receive our costs irrespective of what our charge is. And so we may bill a charge. In this hospital's case, they billed $41 million in charges, but the payers, Medicare, Medicaid, and others, will not be paying our full charge. They're going to be paying a discount off of charges. There's also bad debt and charity care recognized, so that the real revenue that the hospital is expected to generate from patient revenue, from patient services, is around $20 million. It's the $19.91 million. So this is just, it's important to understand the difference between gross revenue and net revenue. Let me go on to say, as I mentioned before, there are three financial statements, two of which we're going to pay attention to. The third one we can toss away for the purposes of this presentation. But the first is the income statement. Now, the income statement, and I want to compare and contrast the income statement to the balance sheet. The income statement is a reflection of amounts earned, revenue, from services generated over a period of time. Whether it's expenses incurred or, revenue incurred or expenses incurred over a period of time. So when you're looking at, when we're looking at this financial statement, this income statement that's showing up here, what you'll see is here's your patient revenue and here's your gross revenue. And it's not just at a date and time. This is the patient revenue accumulated over 365 days. So every day we add revenue to the next day, and then the next day, and the next day. So by the end of the year, the $41.2 million of gross revenue is revenue generated over 365 days, all accumulated. And as we looked at on the prior slide, here's your net revenue. These are the contractual allowances. Net expected revenue about $19.9 million. The next section within your income statement is other operating revenue. In this case, this hospital received grants, they received supplemental payments, other operating revenue, 340B revenue, these types of things. And again, not at any one date in time or one day. It's the accumulation over a 365-day period of time, such that total operating revenue is $22.3 million. The operating expenses show up here, starting with salaries, benefits, and if you look down, you can see them totaling, operating expense totaling somewhere around $19.8 million for a net operating income of $3.1 million, significantly ahead of budget, as you can see. So this is this second column, or third column from the right, is their budget. The second column from the right is the variance from budget. As we go down, so this is looking at then net operating income. Below the net operating income is non-operating revenue. These are, kind of either revenues generated or expenses incurred, not in the normal line of business. For example, tax revenue. Tax revenue can come and go. It's generally recognized by generally accepted accounting principles as a non-operating revenue. Interest income, if you generated some interest income, you don't earn interest in your normal course of business. It's from the cash you generate. It's not from providing services to patients. So these tend to fall under non-operating. But overall, this hospital had non-operating net revenues of $2 million. If you add net operating income with non-operating revenues and expenses, you come up with net income of about $5.2 million. Again, income statement amounts earned or incurred over a period of time. To compare and contrast it to the balance sheet is a bit of a different animal. The balance sheet is the reflection of either assets, liabilities, or fund balance at a very specific date in time. So for assets are resources available to an organization, if you think about them, at a specific date and time. Cash is a resource available. Patient receivables is a resource that will be available. Estimated third-party settlements from payers, amounts that will be available. So these are resources available to the organization. Liabilities are amounts due to others. Accounts payable, you owe vendors, right? So you received supplies from a vendor. You took that into inventory, and we set up an accounts payable because we didn't cut a check at the date they were dropped off. We're going to pay that vendor 30 days from now. That becomes an amount owed to others or due to others. If you look down the liabilities, generally they're set up, they're current liabilities, long-term, then total. Same things with assets. Again, assets are resources available to organization. You have your current, in this organization's case, they had $31 million of current assets. Then they had longer-term assets, restricted and internally designated. Net fixed assets. This is your equipment. This is your building and your movable equipment and your furniture, all net of the accumulated depreciation. So these guys had total resources available to them or assets of $70 million at 9/30/2022. So these were the resources available to them. The liabilities that they owed to others were a total of $13.3 million. The difference between what they have available to them and what they owe is something called net position. Net position or fund balance is an accumulation over all of the years of existence of earnings over time. So at the end of September 30th, 2022, for this organization, because their resources available to them significantly exceed what they owe to others, they have an accumulated positive net position of $56.7 million. If we add the 13.3 total liabilities to the 57 million of net position, the fund balance, the accumulation of earnings over time, we come up with 70 million, which exactly ties out to the assets, the resources that we have available to us at 9/30/2022. So big difference between a balance sheet and an income statement. And now here's where I want to bring it to you. The budget. I hope many of you department managers do participate in your budget, and we'll talk a little bit about the budget. The budget, for the most part, and what you see in the departments is essentially it's a form of an income statement where you project out your performance, not just as of one date and time, but an accumulation of days throughout an entire month, a year, month, and then often a year. The way the budget looks for this hospital is very similar to an income statement. Generally, it starts with the current year, actual year to date. When we're accumulating, again, broken out by gross charges, contractual allowances, other operating income, non-operating income, other operating income. Then you have your expenses, operating loss or gain, non-operating, and then all below. Generally, the budget is set up where you start with kind of 6 to 8 or 7 to 8 months year to date. We annualize it, and then we put together the budget. Some of the high levels, it's a statement of anticipated revenue and expense. It's used to plan, monitor, and motivate future performance. Used to allocate funds. Effective communication vehicles. And then I think about the budget. I think there's a two for win here. The first win is that engaging your managers and the clinical team in the budget process creates ownership at the ground floor of where the action is within the hospital, right? So engaging those managers. The second is it provides a tool to kind of set plans for the future. So I look at the budget as absolutely critical. It's both a process and an outcome. The process is equally as important as the outcome itself. Some of the successful hospitals in terms of budget characteristics, managers are going to be involved. And not only involved in just the expense piece, but also developing volume assumptions which drive the revenue. What I like to see is budget to actual reports are sent to department managers on a monthly basis, and it's consistently done every certain day of the month, whether it's the third week that budget to actual is sent out. There's actually required variance analysis. Pick a threshold for variance, maybe 10% off of budget that your actual performance is, and we require a variance analysis, someone to report on why that happened and what we're going to do to fix it. Departmental, I like to see budgets that have key department performance indicators, maybe an indicator around staffing efficiency, one on volume growth, but have these and create these ratios so that at the end of the month or the year or the quarter, a manager can look at their performance in these key performance indicators and say, wow, we've had a good month or not such a good month, a good year or not such a good year. Now, I do want to just stop and say one thing about budgets. I'm going to go back to slide 8. Often when managers receive these budgets during the course of the year, they're often in the form of just gross revenue, which you'll see right here, the top 3 lines. In this hospital's case, the gross revenue is $56 million. So if you're an imaging department director, your gross revenue may be $5 million. The contractual allowances are often not provided as part of the monthly budget to actual report that's sent out. And so you're starting off with gross revenue of 56 million, or imaging revenue, total hospital gross revenue of 56 million. The imaging department, let's just say, is 5 million. The expenses are here. And let's just say your expenses in imaging are $1.5 million. So a department manager, kind of uninformed, is saying, wow, I'm generating revenue of 5 million. My expenses are only 1.5 million. I am generating all kinds of profit for this hospital. There's no way they can be losing because my department alone is generating $3.5 million in profit. The problem there is that what's missing is it's very difficult to calculate on a departmental basis the actual contractual allowances that those are the amounts, the discount the third-party payers are paying off of our charges. And so what we have to think about is, let me just say that, so some managers and even the finance people say, well, I don't like sending out budget to actual reports to my managers because they think they make all of this money and they don't. And I say, well, what's most important to me is that they maintain budgeted levels of gross charges, because that's a reflection of volume, and they maintain kind of expenses at the expense level, recognizing that the bottom line in the imaging department's $3.5 million profit is not a real profit. because contractual allowance has not been adjusted off. So I would argue that having these budget reports sent out on a monthly basis with required variance analysis is absolutely critical to accountability and creating accountability throughout the organization through measurement. All right, so let's talk a little about the payment systems within our hospitals and physician practice. And I'm going to go through this relatively quickly because we've got a short amount of time, and these slides can be used as a reference anytime. They'll be available through the center that you can pull. But for the most part, most services within our hospitals are paid under a prospective payment system, meaning a fee schedule. The payment is determined prospectively, not retrospectively. And I'll put a big asterisk around this because there are some hospitals, like critical access hospitals, where this is not the case for Medicare. But it is the case for nearly all other payers, other than your cost-based payers. Some states, Arkansas, they pay cost-based Medicaid, but to critical access hospitals. But essentially, most of our payment system outside of the critical access hospitals and Medicare and Medicaid reimbursement is a prospectively determined payment rate, and it's whether it be inpatient based on diagnostic related groups, DRGs, or outpatient based on ambulatory payment classifications, APCs. It's all forms of this prospective payment. Again, the inpatient is based on diagnostic related groups. Essentially, what a diagnostic related group is that there's, with the MSDRGs, there's, I don't know, let's just say there's 500 separate DRGs or services. Each service has a weighting. And the weighting has been set. It's a weight relative to other services provided. And the payment is that weight for that DRG multiplied by a standard payment rate. And we'll talk a little about that in a minute. On the outpatient side, it's the same thing. Ambulatory payment classifications are forms of weighting, and each APC has a weighting that's paid based on a flat standard rate adjusted for regional geography and kind of the service area and or the region and the costs, the wage rates in those areas. There are special reimbursement models for many rural hospitals or special classification hospitals, sole community hospitals, Medicare dependent hospitals, rural offender centers, and then critical access hospitals. We'll touch on those in a minute. So inpatient prospective payment, hospitals paid on DRGs, diagnostic related groups. The payment is a per case inpatient payment on a per inpatient case. It's a diagnostic related group case weight multiplied by a base payment rate. And again, every service has a DRG case weight that's multiplied by a base payment rate. DRG is a grouping of similar clinical conditions. Base payment includes an operating standardized amount and capitalized standardized amount. So what that's just saying is that there's a piece of this base rate that's to pick up and pay for wages, operating costs, and capital costs. And they all form this base payment rate that's multiplied by the DRG, and that's how inpatient services are paid. There's some add-on payments, and there's graduate medical education, indirect medical education, disproportionate share, bad debts. All of these are add-on payments. And then for those participating as inpatient prospective payment hospitals, not critical access hospitals, there's quality programs where there's either pluses or minuses based on value-based purchasing, hospital-acquired conditions, readmissions reductions program. All of these are additional quality payment adjustments. On the outpatient side, it's very, very similar to the inpatient, but instead of calling the services in a diagnostic related group, they're sorted by ambulatory payment classifications, APCs. Each service is assigned a APC, which has a weighting. The national unadjusted payment rate determined based on prospectively established relative weight of that APC by a standard conversion factor. And that conversion factor is calculated based on national average costs with some changes based on the wage index within a certain area. So if you live in a more expensive area, that wage index is higher, so that this payment rate, this standard payment rate is higher than if you are in a low, the cost of living is very low. There are some add-on payments here, as mentioned, and then there's adjustments based on quality. So very similar, the inpatient and outpatient payment systems are set. There's special hospitals, there's sole community hospitals. Essentially, these are hospitals paid under the DRG system or respective payment system that are more isolated. And you can see the general criteria here. There's around 450 of these in 47 states. And you can see, again, I'm not going to get into all the specifics, but you have to be of some distance from the next nearest like hospital. And the way the payment is calculated for them is on the inpatient side. We go back and we look at a base payment rate in 1983. We trend that forward to 1980, gosh, what is it, 6 or 7? You take the higher of that, you trend it forward to 1996. You take that amount, you trend it forward to 2006. Whatever is the highest, you compare to the current rate, this base rate that's paid today, and you take the highest of those four. They also receive a 7.1% positive adjustment on outpatient prospective payments. So they get a flat add-on payment. And the other benefit is that they can, regular acute care hospitals that are not sole community providers, if they're able to tap in, they're eligible to participate in the 340B discount drug program if they have this disproportionate share payment rate at 11.75%. Sole community providers are only allowed 8% or can achieve or can enter into the 340B if their disproportionate share rate is 8%. Disproportionate share, what's that? It's a portion of Medicaid patient days divided by total patient days. And that ratio kind of, it's Medicaid and Medicare SSI, so dual eligible days. You add those two together, divided by total days. You run it through a calculation in the instructions of the cost report, and that adjusted rate has to be greater than 11.75 to participate in 340B for acute care hospitals, greater than 8% for sole community providers. Medicare dependent hospitals, another form, less beneficial than the sole community provider because there's no adjustment on outpatient services. There's only about 160 of these, but there's an add-on for inpatient services if costs in your base year are higher than your current costs. In order to qualify, you have to have more than 60% of your patient days, your inpatient days have to be Medicare Advantage. And then critical access hospital. Many of us are critical access hospitals out there. There's over 1,350 of them in the United States right now. And again, the criteria is here, no more than 25 beds. You have to meet federal distance criteria. And then essentially the payment model for the critical access hospital is you get your costs. So you submit a cost report every year. The cost report determines what percentage of your costs relate to Medicare, and both on the inpatient and outpatient, well, in and swing bed. And when I say inpatient, it's acute and swing bed, and then outpatient. You figure out what your costs are, and Medicare will essentially pay those costs. And again, many rural hospitals have gotten into critical access hospital as a savior. Low volume hospitals with high fixed costs the critical access hospital seems to work. Around physician payment, the physician payment is structured a lot like the APCs and the DRGs for hospital services, in which every CPT code, every service, whether it be an office visit or a surgical service, has a CPT code. And each CPT code has a weighting, and that weighting it's a three-part calculation. And you'll hear the term relative value unit. There's three components of the relative value unit slash or RVU. It's an RVU, people call it. There's a work component. And so there's a work RVU. Work RVU is a weighting. For example, a established patient intermediate office visit, which is a 99213 CPT code. That has a total RVU value of 2.68. That's broken up between the work component, the physician work component, the provider work, the practice expense. How much is the practice, the cost of the practice in a weighting, a relative weighting, and then the malpractice. You add these three up, and it comes up with, in the case of the 99213, a weighting of 2.68. Generally, the physician, the provider work component is about half of the total. The practice expense is about another 90%, and then there's a small amount that represents malpractice. Each of these is affected by something called the GPSI. So the GPSI is the geographic pricing index. And so if you live in a high cost area, that GPSI is a little positive adjustment. If you live in a low cost area, it's often a negative adjustment. But anyway, you add up these three, they come up with your total RVU. In the case of the 99213, it's 2.68. That 2.68 then is multiplied by a standard conversion factor. Last year, 2023, the conversion factor was $33.89. It's falling. I believe that's what it was. This year, it came down about 3.45%. And so it's something less than the 33.89. But would have to determine a physician fee schedule, then you multiply the RVU, the relative value unit, the 2.68 times the conversion factor of last year 33.89, and you come up with a payment amount. And that's how the physician fee schedule is determined. And I think there are exceptions. The rural health clinic and the federally qualified health centers both are exceptions to this standard type of payment model. This is lots of information here on the rural health clinics, and ultimately what happens is up until the December 27th, 2020, when the Consolidation Appropriations Act of 2021 was passed, rural health clinics, provider-based rural health clinics owned by hospitals less than 50 beds received a full uncapped cost-based rate. They called it the all-inclusive rate, which included the physician compensation and or the provider compensation and all other allocated costs through the cost report. Effective January 1st, 2021, new RHCs are going to establish a base rate. And I believe I have that base rate. Yeah, the base rate it's a statutory increase each year through 2028. Right now in 2024, the standard rural health clinic Medicare payment rate for non-grandfathered rural health clinics, i.e. those established after January 1st, 2021, are being paid $139 per visit. That will be $152 next year, and so on and so forth. The next area, and there's a lot of talk here around the payment systems are evolving from a fee-for-service payment system to a value-based payment system. We hear lots of different forms of people use value-based payment interchangeably with population-based payment or ACOs, or you hear people talk about all the different types of conventions. What I just wanted to do here was just show a short little bit of information on value-based care. So value-based payment. I look at it as a mechanism where providers monetize the value derived from increasing quality, reducing cost. That's how I think about value-based payment. And there's lots of different means of value-based payment right now where providers benefit from increasing quality, reducing cost, whether that be accountable care organizations or the value-based purchasing program or your own employee health plan, provider-sponsored health plans. All of these are opportunities for value-based payment in which the providers, the hospitals, the physicians benefit from increasing quality, reducing costs. Some of the other terms used to describe population-based payment, accountable care, value-based payment, but nearly all forms require some form of risk. And for example, if you have a self-insured health plan in your hospital, the hospital is incurring some form of risk that their employees don't incur a significant amount of healthcare costs over and above actuarially determined amounts. Full risk, the total cost of care, where a hospital says, "Hey, we want to go all in. We're going to take full risk from Medicare. We will receive a capitated payment amount, and we're going to use that to cover all the costs of care." That would be the form of a total cost of care capitation. I look at it and say there's a continuum. Over time, as providers take on more and more risk, they move up the scale here, starting off with just straight fee-for-service payments, as we just described in the earlier slides around APCs, DRGs, physician fee schedule, CPT code billings. So we can start off with third party, then we can look at, kind of patient-centered medical home care management fees as a form of payment that's moving away from straight fee for service. We can look at quality-based revenue enhancements, where provider organizations that are engaging with health plans around quality initiatives get additional fixed payment. Again, or a lot of the new Medicare REACH programs and primary first model or primary care first model. All of these are forms of quality-based revenue kickers. To ACO, shared savings, we can enter into contracts where if you're able to bring down the total cost of spend relative to a budget that you received, you're able to share in some of that savings. A shared risk reward, so this is just looking at shared savings, no downside risk. This is saying shared risk and reward, that if your costs exceed, if all during the year your total claims cost exceed your budget, that you're going to be on the hook for that. If they're below the budget, then you're going to get some benefit of that, some savings. And then finally, the highest level of risk and reward is full capitation, where once a month you get a fixed, I don't know, $1,000 a month per Medicare beneficiary, and you get that payment every month. And how you spend that $1,000 a month to care for those Medicare patients is it your choice? And you got to choose wisely, because if those costs all of a sudden, if your costs significantly exceed that $1,000 a month payment that you receive, then you're going to be on the hook for that. So I see value-based payment in the form of this continuum right here. Back several years ago, Centers for Medicare and Medicaid Innovation defined how they see payment progressing over time. Originally from straight fee for service that we just talked about, DRGs, APCs, to fee for service now with link to quality and value. That was kind of, if we go back to here, it's in this range right here. So think about that as, fee for service, but now we're getting paid for some value. We may be getting annual wellness visits. There's payment for health in the form of fee for service. There's quality incentives. If we're able to maintain certain levels of emergency room throughput or something like that, there's incentives, there's kickers. So that's this category 2. Category 3, these are when you start to look at alternative payment models like ACOs, but they're still built on a fee-for-service architecture. And then finally, Centers for Medicare and Medicaid Intervention, think that the payment is going to move to population-based payment built on a population-based infrastructure. I think Kaiser is one of the only few in the country that actually have figured this out completely, where revenue to them is premium dollar, and then they take those premium dollars and invest as a resource allocation to essentially maximize that residual claim on health. That if they can improve the health of their community, they can benefit from that. So that is kind of how, kind of the world of value-based payment in a nutshell. The last one is, I think I mentioned this earlier on, is that I get to travel around the country. Yesterday I was outside of Washington. Next week I'm going to be flying into Kansas City, working with a hospital there. Week before I was out in Honolulu, working with all the critical access hospitals there. So I get to travel around the country, and I've been doing it now for 27 years. And what I've found is that there are three things that when a hospital does these three things, they tend to outperform either past experience with that hospital itself or anybody else that doesn't do these three things. And so what I like to say is that when organizations, if they're going to start to get in trouble, I look for these three things as key kind of processes or mechanisms to improve the performance of the hospital. I'll start off by saying those three things. Number one is an abundance mindset, and we'll talk a little bit about that. Number two is a fundamental understanding of economics. What drives improved performance within our hospitals and from an economics perspective? And the third is a measurement culture. And when organizations do those three things really well, and I have case study after case study of hospitals going down, down, down in terms of financial operational performance, new administration comes in with those three fundamental kind of beliefs or tactics, and the hospital will turn around in 6 months and be very successful. So the first one is an abundance. And this comes out of the 35-year-old book, 7 Habits of Highly Effective People by Stephen Covey, where he compares and contrasts abundance to scarcity. Think of scarcity as a mindset where there's a pie of success in the world. And Tabitha, if you're successful, you just took from my pie. I don't like that. I want to have all of the pie. So I am going to hoard information. I'm going to not give you credit. I'm going to take credit for things that you've done. And what I've found is in hospital leadership, often the scarcity-based people rise to the top they rise to the top. On the other hand, abundance-minded people, they have this mindset, there's a pie of success of the world. And Tabitha, you're successful now. That pie just grew for everybody. So I want a bunch of Tabithas around me so that the pie for everybody grows. And what I've found is that in kind of the minority of hospitals that I've worked with that have that abundance mindset, it just creates an entire different organizational culture than a scarcity based. It engages everyone. And back to my earlier comment when I said often what happens is the scarcity people rise to the top. And I had this experience on my own back 27 years ago, and it's the reason why I joined Stroudwater, was that the abundance people are interested in all other. They want to take care of others. A scarcity-based person wants to take care of themselves. And when that happens, often an abundance person walks around with a bullseye on their back. And so often we see the scarcity rise to the top and the abundance getting taken out somewhere along the way. But number one keys to organizational success to me is an abundance mindset at the top of the organization. The second is a fundamental understanding of economics and what drives performance. The key driver there is contribution margin. All right, what's contribution margin, Eric? You're sounding like an accountant again. Contribution margin is revenue, what you generate in a service. You provide a patient, you admit a patient this afternoon. You're going to get paid $2,500 for that patient day. Contribution margin is revenue less variable cost. Variable costs are costs that change with changes in volume. So if you think about that, we admit this patient this afternoon at 3 o'clock. Your variable costs are tiny. They're food, they're pharmaceutical. You're not going to change your staffing model to account for one patient admitted today. And so what happens is in a rural hospital, what I've found in my travels is that variable costs, if they're 15 cents on the revenue dollar, it's a lot. So we have a whole lot of fixed costs. 85% of our costs are either fixed or step fixed. What that creates an incentive around is every time we provide additional units of service, we generate, dollars for which costs are 15 cents on that variable cost is 15 cents. We've created significant contribution margin over and over and over again. And every time we do that, we create a new service that dilutes that 85% of fixed or step fixed costs over additional units of service. And folks that understand that and are tied in with an abundance mindset know that the answer is growth, reduce outmigration, provide new services to your community, do everything you can around community outreach. Those are the keys to efficiency. I would say, the most efficient means, or the best way of becoming more efficient is to figure out a way how to keep some of your outmigration local. And that's how you become more efficient. So step one, abundance mindset. Step two, economic philosophy. And then the third is a measurement culture. And, back when I went to my MBA program at the University of Rochester, one of their big kind of concepts was around organizational design. The concept being such that the organizational design is a three-legged stool of where we set decision rights within an organization, how we measure performance, and what's the compensation system. And these three are connected. In a hospital organization where site-specific information is critical to effective decision-making, the key then is to drive decision rights down so that the people with the specific information have the decision rights to do what's right on behalf of the organization. So we want to push decision-making down in the organization. If we're going to do that, we ought to be aligning their compensation within with the best interests of the organization. So we're going to push decision-making down where people can leverage up some of that site-specific information for the betterment of the organization. Then we should recognize and reward that performance with merit-based compensation, really merit-based compensation. That's how I look at that. But the third leg of the stool is that if we're not providing information for those department managers to see the impact on the decisions that they're making, and providing information, performance measurement information at the top of the organization so that the leadership team can keep their finger on the pulse of what's going on in deep in the bowels of the organization, we could have a potential issue there. So this three-legged stool of where we set decision rights, how we compensate, and then how we measure performance, and getting that stool to stand straight is exactly right. I had the former chairman of the organization I was at. He made a statement one time, and it rings true today. He said, in an organization without measurable outputs, politics will rule decision-making. I look at this middle bar, performance measurement, and engaging managers with information. For example, the budget, as we talked about, engaging them in financial statements, engaging revenue cycle in key performance indicators, having a quality program that's focused on with performance measurement. All of these are opportunities to take politics out of decision-making and engage our entire staff. So back to this point, when I want to see a hospital do better, or, I look for these three things: an abundance mindset, fundamental understanding of what drives performance through economics, and then, driving accountability throughout every nook and cranny of an organization with performance measurement as the three keys to success. So, Tabitha, and open it up for discussion, but there's just you and me. So not sure if as listening, you may have a question or two, or I'm not sure if we're out of time or not.
We do have just a few more minutes, and I did have a couple of questions for you. So if we go back to the balance sheet
Yeah.
and the income statement,
Yes.
on the balance sheet, it's income, income is considered an asset. It is referred to as asset, while on the income statement, it's called revenue. Can you kind of tell us the difference of why it's labeled that way?
Interesting question. So the balance sheet is really just an accumulation of resources that you have available to you. So, for example, on the income statement, we were recognizing revenue. We were bringing in cash. We were recognizing revenue. Originally when we're booking it, we're booking the revenue. We provide a CT service today. It's $1,000. We will book that revenue as an accounts receivable on the balance sheet as a resource available in the future. And the income statement, we will recognize it as revenue. It's income generated. When the cash comes in, what we will do is, let's say $1,000 comes in. The accounts receivable will get rid of the accounts receivable because it's no longer the cash came in, and then it shows up in the cash. So the income statement is revenue generated over time from services provided. The balance sheet is a statement at a certain point of time of all of the cash that's been generated, less the expenses that have been paid out at a certain date and time. You're still
That makes
looking.
sense.
Yeah.
No, I'm following. I'm following. I
Yeah.
just was, it's sometimes if you're not familiar with financial terms, when you see it called revenue one way and then asset, and sometimes you're thinking asset as, a truck, more fixed like a
It,
desk because in personal finance,
yeah.
assets are tangible things. So it can be confusing whenever you look on them and you're like, well, it's revenue here, but it's asset over here. And what's the difference between revenue and asset, on the income statement or the balance sheet? I mean, so
That's a really, I'm glad you're asking this, because these are the questions that us accountants are, the people in the business, anybody in finance just assumes you get this. And you're asking questions that the clinical people are afraid to ask. So again, an asset, to some degree, it is a tangible thing. You can go to the bank and you can cash that check. Right? The accounts receivable. Now, while you can't, an accounts receivable is a tangible thing. You will receive that cash. It's like it's an IOU, or IO, yeah, somebody's IOU to you, is what that accounts receivable. So it's tangible. You can hold it. Just like you can hold cash, just like you can hold equipment, just like you can hold inventory. All of these are resources available for use within that organization.
that makes sense. Thank you for explaining that. I do have one more question for you. So we were talking about the income statement is for the whole year, for 365 days. But we were also talking about sharing the balance sheet and the budget summary with managers on a monthly basis to get their feedback on any variances, let them know where they are financially for the month. But how often should we really be looking at income statements? Is that end of the year when taxes roll around, or is that something we should be looking at a year to date basis every month?
Really great question, and you're going to allow me to clarify because I probably misspoke. An income statement is it's the accumulation over some period of time. That period of time could be a month, could be a quarter, could be half a year, could be 7 months. It could be any time frame that we select. Generally, hospitals look at income and expense on a monthly basis. And then they look at it, for that month itself, compare it to the budget for that month, both income and expense, and then the year to date, whether that year to date be 2 months year to date, 8 months year to date, 9 months year to date. It's really the time period that's relevant and most current. And it's not the balance sheet, right? So it's the balance sheet kind of is there's these resources available to or amounts owed to others that kind of sits on the side. What you're going to see as department managers is that income, it's your piece of that income statement, right? All of the revenue generated over a period of time, whether it be this month or this 2 months or 3 months or 4 months, the revenue generated and the expenses paid out. So that's like more of the income statement that we look at.
That makes sense. So we were talking about variances, and this is my last question. So we were talking about variances, and I understand that the variance between what you said you were going to spend in the budget and what was actually expensed. So how do I start, if I was a clinical director, how would I start looking at those variances to find out what happened without those breakdowns of expenses?
Well, generally, I mean, I always say transformation starts with changing the questions being asked. And when I see a variance, let's just say my supplies expense, I had a $10,000 budget this month. This month actually came in at 20,000. And I'm required to report on any variance from budget of greater than 10%. So I'd have to report on this. So the first thing I'm going to do is ask why. Often the accounting folks can provide a breakdown of what were the expenses that you spent on that month, such that you can then provide that feedback to your CFO. Hey, there was a one-time supply expense. This drug came in; it was really expensive, and that would be the explanation for that. So
Okay.
So I do like the fact that you're asking those questions, because that means you're paying attention to your business. And I will say though, as I travel around, there's probably still 25% of rural hospitals out there that don't provide their budgets and budget to actuals or engage the department managers in the budgets. The budget is something the CFO and CEO go away for a weekend and come out with the budget. They get the board to sign off on. And then it's often just kept within its own. I mean, I'd say, like I said, probably 20-25% of rural hospitals still do not engage their managers in that budget process, or that budget to actual variance that you just talked about. I'd like to
That's a
see that number.
scarcity mindset, kind of don't
Well,
include them, or is it more of a they don't know to include them?
often it's the main reason I hear for them not sharing or engaging is that they're clinical people. That's not their business. We've got the business side, they got the clinical side. And again, as I traveled around the country, what I've found is organizations that bring together the business and clinical side together, they will be more successful than they'll allow those two to operate side by side, because that creates they and and us and they, and we don't need that. It's a we.
Well, that's all the questions I had, but thank you so much for your time today.